is Yinka Oladele, and I'm with the African Cancer Support Group. What we do is we offer services to cancer patients, cancer survivors, caregivers, and their families. We bridge between the hospital and their home. Where people are treated at the hospital, some of the information and resources that they could not get at the hospital. So we are able to provide them. And some of the things that we provide includes culturally appropriate meals. We help them with their house cleaning. We provide culturally appropriate counseling. We have registered counselors, registered psychologists. We have registered health coach, and we are able to meet with cancer survivors and patients where they are. Today, my guest is Mr. Tuoyo Abati, a registered oncologist nurse with Tombeka. How are you, Mr. Abati?
I'm fine. Thank you for having me.
Thank you. Can you tell us briefly about yourself?
Okay. Where do I start? My name is Tuoyo Abati. I'm a Nigerian. I immigrated from Nigeria to Canada about some 22 years ago. I was in Montreal. I arrived in Montreal. I did my nursing studies and training at Montreal. Thereafter, when I finished, I went, started working at the general oncology unit there at the Royal Victoria Hospital. And I think about in 2006, I moved out here to Calgary, worked on a general surgical floor, and subsequently I transitioned to the Tombeka Cancer Center in 2013. I'm married, I'm with 3 kids, kind of adult kids.
Wow.
I think that's about it.
Wow, thank you.
You're welcome.
As an oncology nurse, what can you tell us? Because I know that when they say oncology, when my husband was diagnosed and I heard the doctor say, okay, we have to refer him to the oncologist, I went to check the meaning of oncologist. I'm like, that's the doctor of cancer. Oh my God, did he have cancer? As at that time, they've not told us that he has cancer. I just heard them whispering. So can you tell us what oncology nurse, what do you guys do?
Okay, well, like you said, oncology is another term for cancer. If you want to kind of make it more, kind of like use the layman term, the language that people will understand. So we're pretty much, I'm a cancer nurse, right? And typically what we do at the cancer center, we receive referrals from the community. Just like you said, when your husband was referred by pretty much the general practitioner, the physician, to the cancer center, it's okay. And so what we do, we do specialized kind of training and investigations in relation to cancer. We do more tests to confirm the diagnosis that this is cancer, this is what we're doing, we're dealing with. Once we have that definitive diagnosis that this is cancer, that this is what it is, then what's the next step? Okay. So then we initiate in terms of treatment planning going forward and those kinds of things. Yeah.
Wow. As a Nigerian, who is a cancer nurse? I'll call it cancer nurse because the word oncology is that's kind of
it's a big word. Yeah, it's a big word. Yeah.
I'll call it cancer nurse. I'm sure you have dealt with so many people with cancer. So let's bring it back home to our people. Our African people. We are from Nigeria, we are African, we are Black. So what do you think when you hear that a Black person has cancer?
Well, a couple of things. From my experience, I've dealt with some of my patients that have been Africans, Nigerians, and whatnot. I guess the major thing with us Africans in dealing with this kind of cancer, this kind of diagnosis of cancer, is that we tend to deflect, deny, and kind of not accepting of it, right? And so then it opens lots of layers, if you want to say. Because if you're not accepting of something, how do you treat something that is you're not accepting, and those kinds of things, So conventional medicine for us Africans is kind of a challenge, because the thing is, we don't participate in clinical trials. We don't want to do clinical trials. It's very hard for you to get the Black Africans or Blacks into clinical trial programs, right? And this is where medications are developed, right? And for possibly cure and treatment. And so when people don't engage with the healthcare system, when they now have diagnosis of cancer and whatnot, it's hard for you to now start looking for the appropriate support for them out there. And even when you look at the whole support system that we have, at the Tom Baker, for example, there is no specific group that speaks to the Black person or the Africans, or you know what I mean? And so then if they go out to all these groups and they don't see somebody that looks like them, that talks like them, it's very hard for them to have a buy-in. You know what I mean? So,
Wow. In our community, we have the stigma. We have the taboo. I'm still going to come back to what you said. But we have the stigma, we have taboo. What can you say about the stigma and the taboo of our people in relation to cancer diagnosis or cancer testing?
Well, the whole thing about the taboo or the about cancer in our society, in our community, I think it's more of a cultural thing, right? Because if you look at us Africans, we really don't talk about our illness, right? We don't discuss it. We don't talk about it with our kids. We tend to be secretive about those kinds of things, right? And at the end of the day, by the time, for example, our parents, if you ask me, both of my parents are late now. If you ask me, actually, what did they die from? I can't tell you. And even if you look at our community, how we announce death, I don't know if that's changed now. We say die from a brief illness.
That's it, yeah.
Nobody mentions anything. So even the immediate family don't really know what their loved one died from. And so if you don't know, how can you talk about it? How can you find more information about it, right? And so some cancers are genetically transferred. They could be genetic, right? And so if we provide information, awareness out there to the community, to our community in particular, they'll be able to decipher that, this particular kind of cancer is genetic. So what do I have to do? If my mom has it, should I be testing myself? Or is there any test out there to find out if I'm going to have it or if I already have it? And all those kinds of things. Because one thing we know about cancer treatment is that if you discover it early, the outcomes are typically better.
Yes. You are right with that. This is early detection.
Correct.
Saves lives.
Yes.
The other time you talked about the conventional treatments. And in our community, we have what we call traditional treatments.
Correct.
So can you talk about both of them, traditional and conventional treatments?
Absolutely. So here's the thing. When in cancer care, when we say conventional treatment is typically what you will get in a cancer center anywhere in the world, especially in the Western world. The treatment you get at the Tom Baker Cancer Center is for breast cancer, the same stage and the same diagnosis and whatnot. That's exactly the same kind of treatment you will get when you go to the States or you go to the UK and Europe and all those places. So it's conventional across the board. And the reason why it's conventional is because it's research driven, right? Everything that's done at the cancer center before a treatment becomes standard of care has gone through rigorous sets of clinical trials and all those kinds of things. And before they figure out, okay, they did something in the same nature in the States, and this was the results they get. We are doing it in Canada here. This was the results we are getting. So across the board, it is conventional. It is kind of standard. So we use that, okay? as opposed to traditional or alternative therapies that our people kind of, gravitate towards the traditional. It is not been proven scientifically in terms of traditional medicine. It is kind of like word of mouth, right? Oh, I did ginger. If I mix ginger with lime, you boil the water, you drink it, it's good for you. It's going to cure cancer. Or I drink carrot juice, it's going to cure your cancer. So it's kind of more like testimonial, right? There is no that hard evidence, that data that supports it is not there. And again, when traditional ones treatment, the standard is not there in terms of dosage, like how many of this carrot juice should I take a day, or how frequently should I take it, and for how long, and how do I know it is working? Is it just because X said it's working or B said it worked for them? You know what I mean? And for our community, we tend to gravitate to those kind of things, those kind of treatment, because, oh yeah, this is what that person did and it worked great for them, right? But again, coming back to cancer for A is not the same as cancer for B, right? It's different for this different person and different diagnosis. Breast cancer is a general term, right? If you go down to breast cancer, there are different subsets of breast cancer. And then people respond to treatment differently as well. So it's not one cap fits all, or we don't use one brush to brush everybody. Oh, you have breast cancer because you have breast cancer. This person took XYZ, it's the same XYZ you're going to take. If XYZ work for that, no. We'll look into the subset. What kind of breast cancer is this? How is the breast cancer expressing itself? What is driving the breast cancer? And all those kinds of things. Based on all those information, the oncologist will now say, this is the kind of treatment that is more appropriate for how this cancer is presenting itself.
Wow. Thank you. You mentioned a few things.
Yeah.
Most of our people, we don't like to go for clinical trials. Is there any reason why we don't like to? Has there been a problem for Black people, African people? Maybe they went for clinical trial before and something happened. Or why is it that we don't, in the database, we don't have so many Africans in the database of clinical trials?
Yeah. Well, so many things happen. There are lots of, I would say, in the Black community in general, in North America, we have this trust for Western medicine, for the white man's medicine, just because of some of the experiences that we have experienced as a Black community. There've been situations in the past, in the 50s and 60s, where Blacks were used as guinea pigs, right? In trials and whatnot. People were, especially in the States, Blacks were used just for trying some kind of different medications and theories and whatnot, and the outcome was bad. And so the community knows about all those kind of things. And so people tend to kind of pull back when you tell them about those kind of things. I'll tell you a story about one of my patients that I had. He was from Tanzania. And the first time he came to the cancer center, he was having issues with his radiation oncologist, right? He was like, so you guys are going to take me now and take me to the basement. That's where you have your guinea pigs, and that's why you're going to treat me. And the guy, the oncologist was taken aback by that statement. He was like, what are you talking about? Where is this coming from? This is the first time we're meeting. And so they couldn't even hit it alone. And I was the nursing clinic that day. So the oncologist came out. He's Caucasian. And he came out and said, Tuoyo, look, there's somebody from your community there. Can you go and speak to him? Like, I don't understand what he's talking about. He's here, but he is not buying into what I'm offering here. And he's talking about all this kind of stuff. You know, now this man is an engineer. He's not stupid. The patient, he's an engineer.
He's well read.
He's well read. You know, understand me. So it's not somebody that just, you know what I mean. So I went in there, and I kid you not, when I opened the door and got into the exam room, he said, "Oh, now they want to bring a person like me to come and convince me." It's like, can you imagine? So we have those deep-seated suspicions of the medical system, of the healthcare system, right? Just because of what we've read, what we've heard. So that's one of the reasons why you see the blacks, they pull back from all these clinical trials and all this stuff like that, research and all those kind of things. They don't want to participate because they don't want to be used as a guinea pig.
A guinea pig, wow. I know someone that they asked her to come for clinical trials. She had to fast and pray.
Mm-hmm.
Then she has to call that, please, they asked me to do this clinical trial, but because of all that I have read, that she was actually scared, fear and all those things.
Right.
But fortunately, she went for the trial and she's still on it.
Mm-hmm.
So I think the thing is changing with the right information.
Awareness, absolutely.
And also being able to have a good campaign and awareness, letting people know that, yes, of course, this thing did happen then. I know we cannot erase history.
Correct.
Right? We cannot erase history, but from history, we can be able to develop ourselves, even presently. So for people that are scared of doing clinical trials, what can you tell them?
Well, it's okay to be scared, right? There's nothing wrong with that. It's okay to be scared. But you have to, being scared is one thing, then do your due diligence, okay? Reach out for resources in the community. Look for people in the community that have expertise in cancer care, cancer oncology, and all this kind of thing. Ask for them for their opinion and what do they think about it. Because like you said, clinical trials there are good outcomes from all those kind of things. At the end of the day, you want a better outcome, and if it is going through all these clinical trials, will provide you that avenue to get to a better outcome in terms of your cancer journey, then why not take it, right? Yeah. But then again, the scared part, the afraid part, those are the kind of things that groups like the African Cancer Support Group, they can reach out to groups like that and say, hey, look, from your experience, do you have anybody that has gone through this kind of thing? And can you link me up with them so that I can get their experiences and what it's all about? Because at the end of the day, if we have resources like this cancer support group in our community, I think a lot of good will come out of it.
Yeah, thank you. We know people that have reached out to us that, they asked me to do this. And I try to reach out to some doctors, like some oncologists that, okay, this person is from the community and this is what is happening. And we've had a good response from it.
Good.
Yeah, I want to talk about people going through traditional medicine, eating, they say, when you have cancer, just eat raw vegetables, eat raw something, that chemo is not good for you or something like that. What can you say about that?
Yeah, we've heard those kind of things, whether you call it traditional or alternative therapies. There are people that are patients that have had, they go out there and so do a vitamin C infusion is going to clean out all the cancer and whatnot. And the thing is, all those therapies are not cheap, right? So that's it. Yes, chemotherapy is a cytotoxic medication. But the thing is, it is targeted, it's for its time frame, right? And your oncologist will not say you should have chemo unless he has looked at everything, the diagnosis, the pathology, how the diseases are presenting. And based on that, if it's an aggressive form of cancer, then obviously you want to use an aggressive kind of treatment, right? And so that's what your oncologist is going to do. He's going to tell you to do chemotherapy because he has seen how the cancer is and what the cancer is doing. Left unchecked, the cancer will overrun the body, right? Now, in the case of traditional medicine and all those whatever is out there, like I said earlier on, it's not been proven, right? There is no hard data to support all those therapies out there. Am I saying it's not effective? I'm not saying that. What I'm saying is that, like, for example, if you come to the cancer center, they'll be able to tell you the numbers of people that had breast cancer between the time frame. You can search. We have the cancer registry where you can search, okay? When they were diagnosed with cancer, what treatment they had, how long was the survival, how long did they stay of cancer, and all those kind of things. They were able to give you all those information, right? But if you go to the traditional and say, okay, give me information on that, those kind of things, that's where they are lacking. They don't have those data. Mm-hmm. They know that they're treating people are taking things, but how long did those people survive? For how long? And like I said earlier on, how do you even take all these medications and all those kind of things? So is there a place for alternative therapy? There could be, but do we have that strong data to back up the reason for going to that? We don't. But in chemotherapy, they will tell you, in conventional treatment of cancer, they will tell you that this is what happens. This is people that died during this process, and this is people that survived. They'll quote you all the numbers, right? And so then, it begs the question, right? Like, okay, so why go for that when I don't know who's benefited from it, how long they benefited from it, and all those kind of things, right? Mm. So it's mostly word of mouth testimonials that drive those traditional, and the fact that being diagnosed with cancer is something that is tough, right? And then you want to look at, what can I do? So you're grabbing at straws from all angles, and it depends on who has your ear at that particular time of diagnosis. You might tend to gravitate towards what they are telling you, because they'll say, this person had cancer and they took this herb and the cancer disappeared. So.
Wow, thank you. You mentioned about vitamin C infusion. Mm-hmm. I know some of our members said that, they wanted to take this vitamin C infusion, and the guy actually took it a few times. Mm-hmm. So what can you say about that? You said, not that, of course, you're not condemning anything, but you said, it's not cheap. So are you saying maybe the infusion is good, or?
Well, generally, vitamins are good, right? There's something wrong with vitamins. Now, how are we using this vitamin? Is it curative intent? Are you taking the vitamin C to cure you of that cancer? That's a different story, right? So, like in my practice, if you want to use other alternative therapies, we won't say don't use it. We're going to say, why don't you finish one before you go to another one, right? Let's not mix them up. So if you're on chemotherapy, stay on chemotherapy, finish that treatment. Chemotherapy is not like for life, right? There's some certain time frame for it. When you're done with that treatment and whatever, and if you want to subsequently go ahead and have your infusion and all those kind of things, vitamin C infusions and alternative therapies to make you feel better and whatnot, you can go ahead and do that. The reason why we say all that is that there are sometimes these medications are contraindicated, right? They can counteract each other. For example, if you're taking chemotherapies, there's typically, when you come into the clinic, the pharmacist is going to be there. The pharmacist is going to ask you, what are all the medications you are taking, right? Because they want to look at it. They want to look at it and make sure that none of them is clashing. None of them interacts with each other, right? Because there are some medications that you're taking that might decrease the potency of the chemotherapy drug.
Oh, I see.
Right. So that's where all this comes from, right? So they want to know everything that you are doing while you're on this treatment, so that if the pharmacist looks at it and says, this particular medication, this vitamin, this whatever you're taking, counteracts with this kind of chemotherapy, then the advice would be, stop that for now. Let's focus on the treatment. When we are done with the treatment or whatever, you can go back to this your treatment.
Yeah, thank you. I know that when my husband was diagnosed, the pharmacist came and was asking all type of medication he was taking, including supplements. So I asked him, why are you asking about supplement? He asked if he was taking a magnesium, vitamin C, if he was taking vitamin C, how many in a day. I was asking, why are you asking? So that they wanted to know, so that whether he's not taking too much, or to check whether he should continue to take them or to stop them. So I hear you. Now, you mentioned something about having a registry.
Yeah.
I know that we have cancer registry, but I don't think we have by tribe. Say if you want to know how many Black people have breast cancer in 2022, in Alberta, don't even let us go to Canada, Canada-wide, in Alberta. How many Black people have breast cancer? How many Black people have prostate cancer? What is their prognosis and all those things? Where can we get that data?
Most of the cancer, the data is in the Alberta Cancer Registry, right? And so everything is plugged in there. I think you can search by demographics, right, in terms of female versus male and all those kind of things. I'm not sure if they do it by race, though. You know what I mean? But certainly, all the cancer registry in Alberta here, they putting up all the data. Anybody that has been diagnosed and confirmed diagnosis of cancer, regardless of whatever cancer it is, it goes into the registry.
Wow. Yeah, I don't think they to do by race, because say you are doing a research, you are writing an article, you actually have to go to the South, maybe to the US when you want to, or to Europe, when you want to get data on how many Black people has this type of particular cancer. Or is there any reason why we don't have data about race in Canada or in Alberta?
Well, the thing is, if you want to get that data, you can find it, right? If you really want to, you'll be able to get it. But again, most of when it comes to data and research and whatever, it's driven by numbers, right?
Yeah.
And so we are a minority. We're a really small minority there. And so then, what's the point, right? So, but like you said, but when it comes to research, when students are doing their research, their PhD thesis and whatever, they can do a deeper dive into all these data sets and actually fish out all those information.
Wow.
They can do a race-based research and all those kind of things. But I don't think the government will just come out and say, out front, this is for race and all those kind of things. No.
Wow, thank you. I think I was reading somewhere that African people, Black people die more of cancer. What could be the reason? Is it because we don't get tested on time?
Yeah.
Or I don't know. What do you think could be the reason?
Well, you alluded to it. The reason why most Africans or Blacks will die from cancer diagnosis, as opposed to Caucasian, for example, is because by the time they are diagnosed with the disease, it's at a later stage. For example, let's take breast cancer. The data out there, especially from the States, is that the Blacks that are diagnosed with breast cancer die more from breast cancer as opposed to Caucasian. And the reason being that is that when they are diagnosed, is at the late stage, as opposed to the Caucasians. They are diagnosed at the early stage, and then they get the treatment early, and then the outcome is better. And one of the reasons why, blacks are dying more from this disease has to do with, we don't engage with the health system at the early enough. When we have all these symptoms, we tend to ignore it. We tend to not deal with it. And then we deal with it when the disease is already progressed and whatnot. Wow. Also, poverty as well, right? Like not so much so in Canada, but in the States, you can't access the healthcare system if you're poor. And there are more blacks that are poor than Caucasian, for example. So poverty also speaks to that. In healthcare, we call it the socioeconomic derivative of care, right? Like even in Canada here, for example, if you have access to finance, you can have access to medications that typically, is not funded.
Yes.
So poverty as well results in all those bad outcomes for our community.
But in our community here in Alberta, testing is free. Cancer treatment is free, except some of the out-of-pocket expenses. Yeah. And I'm not sure why we are not taking the, what's the word? We are not taking the opportunity to go out and get tested. So once again, my guest today is Mr. Tuoyo Abati, who is a registered oncologist nurse here in Alberta. So Mr. Abati, what would you like to tell our people, our community, about getting tested?
Right. Yeah. Thank you very much for that. I think at the end of the day, to summarize what we've said so far, when it comes to cancer care and cancer, one thing we know, one of the major risk factors for cancer is age. The older we get, the higher the chances of us getting cancer. So now, having said that, what can you now do? All of us are going to get old, right? So you can't stop getting old. But what can you do to mitigate against to prevent you from getting cancer? That comes the testing, right? There are some certain timelines. If you're a male, African male, black male, before 40, or by the time you're 39, you're approaching 40, ask to get your PSA, because what we know is that prostate cancer is predominant in the black community for men of African descent. They have a higher chances of getting prostate cancer. So then if you test early, if you go out there and get yourself tested for your PSA, the PSA is the test is covered by the government, it's free. Speak to your family physician, speak to your doctor, your general practitioner, that, hey, look, I want to do this test. Even at an early age, at 38, 39, if you're a male. Same thing for women. If you're women, we know that breast cancer is predominant. Breast cancer, ovarian cancer, cervical cancer, all those things are predominant. And there are tests that can be done, so that if you have it, we can pick it up early. Your pap smear test, breast mammogram and ultrasound, all those tests, ask for it. Especially once you are, getting older, you are in your late 20s, early 30s, ask for this test and whatnot. Speak to your family physician, discuss cancer. Okay, what are the resources there? What are my chances? Know your family history. All right, ask your parents if they are still alive. Do we have cancer in this family? Has anybody had cancer in the family? Ask your both parents, maternal or paternal, uncles or aunts. Did anybody have cancer? Is it predominant in our family? Is this something I should be doing genetic testing for? If it is predominant, if cancer is predominant in our family, then should I be doing more testing, genetic testing, and all those kind of things? Because at the end of the day, if you are more aware, then you'll be in better position to mitigate against having this disease.
You've said it all. Thank you so much. Thank you. So to our viewers, thank you for staying with us today. Once again, our guest today is Mr. Tuoyo Abati, the oncology nurse from Tombeka here in Calgary, Alberta. My name is Oladele, and I'm with the African Cancer Support Group. And this program is brought to you by viewers like you. If you would like to know more about our services, you can check our website, africancancer.ca. And our email address is info@africancancer.ca. If you'd like to support us, if you'd like to donate, please reach out to us. We rely on people like you. We rely on donors. We rely on sponsorship. Once again, thank you, Mr. Abati, for coming.
Thank you for having me. Yeah.
Welcome.